Okay, so hi everyone, and welcome to today's webinar at the Follicular Lymphoma Foundation on When FL Changes, Understanding Progression and Transformation. I'm Nick James, and I'm the Research Manager of Patient Programs at the FLF. We're really excited to see so many of you here today. Thank you for joining us. And like I said, please do introduce yourselves in the chat and participate in the polls. And the Q&A box should also be open, and you can choose to ask your questions anonymously as well. We'll get through as many as we can in the session. This webinar is part of a series and it takes place every other month. And I'll put in a link in the chat so you can register your interest for the future webinars. And all our previous webinars are on the website in your support hub, and I'll post a link to that as well. So just to let you know that this webinar is being recorded and we'll upload it to our website, and only the speakers on the panel today will be able to be seen. And yeah, let's get going. So over to you, Mitch.
Thank you for the introduction, and thank you all for attending. Happy to be able to provide this information, and very excited to have our panelists, who I'll introduce in a minute. So we're going to talk today about when follicular lymphoma comes back, particularly when it transforms to a more aggressive form. We've asked the follicular lymphoma community, and this has been a clear topic of interest, and it clearly is one of the concerns of patients and their physicians. So we're going to talk about when you are in remission, what you can watch for about recurrence, and also this question of, has it changed form from a indolent follicular lymphoma to a more aggressive form. My name is Mitchell Smith. I'm the Chief Medical Officer of the Follicular Lymphoma Foundation, and just before we introduce our panelists, there will be a series of audience polls. We really appreciate your taking part in those, so we learn who the audience is, who's listening, and you can see the first one up there. So those will come, and we'll come back to the results later, and then we do some during and some at the end to see if we've helped you understand this topic. So the information and discussions we have today are clearly not individualized, so they are for informational purposes only. They do not constitute medical advice, so please consult your own healthcare team for medical advice. The polls are up. First is, what's your level of understanding of follicular lymphoma progression and transformation? Anything from not clear at all to I'm very clear. As they come up, we'll look through the others. Have you experienced progression or transformation, and what's your biggest concern? So as you're going through those, we're going to introduce our panelists. I'm really excited today to have Dr. Carla Casulo with us, and Fiona McMullen, who's a patient who's going to share her story and her insights with us. I'm going to ask Dr. Casulo to introduce herself first, but I do want to point out that she's really defined, her paper has really defined the question of transformation and the risk of recurrence early. This is called progression of disease in 24 months, or POD 24. So she's really a leader in the field, and we're very excited to get her insights today. Carla, you want to tell us, introduce yourself?
Good morning or good evening, depending on where you are in the world. Thank you so much for the invitation. Again, Carla Casulo. I'm an associate professor at the University of Rochester, Wilmot Cancer Center, which is in upstate New York. And my research focus is on follicular lymphoma. Primarily, it's understanding the factors that lead to someone experiencing early progression of disease and transformation, and trying to define treatments for those patients, as well as working from large patient registries and consortia to really understand risk factors and risk modeling for patients, so that we can understand who is hopefully going to do very well and who might need some additional attention. So again, I'm really delighted to be with everyone today.
Yeah, thank you for pointing that out. I think it is that what happens in large data sets in a heterogeneous disease like follicular lymphoma is really important, because everyone is a little bit different. Fiona McMullen joining us, so maybe tell us a little bit about where you are, and we'll cover your story in more detail later.
Hi everyone, I'm Fiona from Perth in Western Australia. I was diagnosed with follicular lymphoma in 2015, so 10 years ago now, and transformed 2 years later into diffuse large B cell, which I had treatment for, and I've been on watch and wait since then.
Great. So we'll feed into that and some of your insights and thoughts about things. So before we head into the content, so we're looking at our audience. What's your current level of understanding of follicular lymphoma progression and transformation? Actually, 40% are in the middle, 3 out of 5. There's only a rare person who feels really comfortable, and a few people who know nothing about it, and a few people are in the middle. So it's a good distribution. And we will try to address that. But it sounds like there's some knowledge base in a significant number of people. And the second one up, or is that?
I think you can scroll down, Mitch, and you should be able to see them if you can't see my screen.
I must have disappeared. If you can put it up again, or. There we go. Oh, my bad. Okay, there we go. So have you experienced follicular lymphoma progression and transformation? The majority, almost 2/3, are saying no, but are concerned about it happening. And I think that's why this is a popular topic among patients, because you're sitting there waiting for something that's unpredictable. So we'll talk about that. And 16% had progressed, and 10% have had a transformation that they're aware of. So that's a good mix there. And the biggest concern, I think, again, 80% of people, it's multiple choice, so people can put it, but 80% are this idea of uncertainty, not knowing if and when it will change. And a lot of people, 2/3, want to know about treatment options, and then almost half interested in how it affects your quality of life. And some people obviously concerned about finding the right doctor treatment center, since this is sometimes a specialist knows a little bit more about it. And the emotional mental health impact, I think, goes in with the quality of life, which is also, again, a major concern appropriately for if it's going to happen, when it's going to happen, and how it's going to affect me. So we will cover many of these things, and we thank you for the questions you've submitted. We'll try to incorporate those into the discussion and come back to any that we miss later on. All right, so let's get going with the information. So, Dr. Casulo, when we did cover recurrence in a previous webinar, so I don't want to spend too much time on that. But people are sitting there worried about, is it going to come back? How do they know? And how do they know whether it's come back as an indolent or more aggressive, the role of biopsy, things like that? So maybe what you tell a patient sitting there when they finish treatment, how you approach that, and we'll give you a few minutes to sort of educate us.
Sure, absolutely. And I think those are really important questions. So I think that the first thing to bear in mind is how someone was diagnosed to begin with, because often it may be similar symptoms that lead someone to have their recurrence diagnosed. So perhaps someone identified, felt a lymph node under their arm or in their neck or in their groin, and that led to the diagnosis. So occasionally experiencing similar symptoms like that, or fatigue or night sweats, perhaps. Alternatively, sometimes people are diagnosed accidentally. So perhaps in the setting of a mammography, there were no symptoms, or in the setting of some other imaging for an unrelated reason. And then it's a little bit harder to sort of identify that symptom because there was no symptom to begin with. When someone ends treatment, though, what I tell my patients is that you should trust yourself. Trust if something doesn't feel right about your health. If you had been someone who was very active and now you don't feel as active, if you were someone who had a lot of energy and all of a sudden, you don't have energy anymore or as much, and there isn't really a very good explanation for it, or if you have noticed a lymph node that has appeared and hasn't resolved itself, I think those are some of the things that you really need to trust yourself and seek medical attention for. Occasionally, though, routine surveillance will also identify a recurrence. And guidelines are now shifting away from routine surveillance in follicular lymphoma because not much may change based on what we find. So if someone, if we identify a lymph node that's, let's say, a centimeter, we don't consider that a very actionable size because we know that follicular lymphoma can remain stable for a very long period of time. And so, yes, watching that and following that trajectory with imaging is important. But if you think about this as being a chronic illness that someone may have for many, many years and live with for many, many years, we also need to balance that against excessive exposure to radiation and things that could increase one's risk of having other problems later in life. So it really is a very careful balance. And that's what I tell my patients. If I identify something on the physical exam, I would want to follow up on that. And to your question about how can we tell what it is if it does come back, a biopsy is the gold standard because occasionally someone will have a lymph node that we don't biopsy rather, and then it completely disappears in a few months. And so we don't want to make an assumption that something's lymphoma without a biopsy.
Yeah, very good point. So I think, yeah, is tell patients you know your own body and be aware of things. And I think it's important to say, you can have an infection or a flu or something else and you'll have enlarged lymph nodes, but they go away. You have a reason for it and they go away, as you point out, that not all lymph nodes come and stay. So it's in the right setting of it lasting. And I think your point about surveillance, yeah, it's definitely been a switch from very frequent scanning to, is it going to make a difference in what we do? If we're going to watch anyway a small lymph node, then it's not necessary to do frequent scans.
Right, exactly.
So one of the questions comes up is the difference between a CAT scan and a PET scan, and do you have a preference for
That's a great question.
surveillance versus when you're about to start something?
Right. So, the PET scan and the CAT scan give us slightly different information. I view a CAT scan as sort of like your black and white picture, and the PET scan is in full color because the CAT scan gives you anatomy and size. However, a PET scan gives you that plus metabolic activity. So when you have a PET scan, you can see the same thing that you see on a CAT scan in slightly less definition, but you also have the additional benefit of understanding what is the metabolic activity, how much energy is that lymph node using, and how is that different from normal? So all of our body has metabolic activity. Our liver has usually one of the highest levels of metabolic activity because it makes proteins, it's filtering and metabolizing things in our body. And so I think about the liver as the hardest working organ in your body. And so when we look at a PET scan and we interpret it, we have that comparison from your liver baseline. My liver baseline will be different from your liver baseline. And so everyone's PET scan will have a different, what's known as a Doval read or a Doval score. And so the PET scan will compare energy uptake from the lymph nodes or other areas compared to the liver. And that's how we can tell whether something is worrisome and needs to be pursued or not. So I view those as the two major distinctions between the two tests. Also, some sort of logistical differences are that you need to fast differently for a PET scan because it uses energy and that's based upon sugar utilization. People have to have a low carbohydrate diet before a PET scan, and that's a little different from a CAT scan. And the test also takes a little bit longer to administer compared to a CAT scan.
So do you do routine surveillance or only if someone has symptoms or you feel something, or what's your sort of approach?
Yeah. I mean, my personal preference, and this is again my own practice, everyone has a slightly different take. I do like to do sporadic imaging, particularly at the 1 and the 2 year mark. I don't necessarily find every 3 or 6 month CAT scans to be that useful, and I believe that can add some component of anxiety as well to a patient's sort of life trajectory. When you're separated from your lymphoma treatment, now you sort of want to re-engage in life again, and having the constant imaging can sort of draw you back into that space where you are probably doing very, very well. But because of the risk of early disease-related events that we've defined, I do like to identify whether someone has an early event, or what we call early event means progression. And perhaps we might want to follow that patient slightly differently or offer them a different intervention. That happens to be my practice, but recognizing that many, many oncologists have slightly different approaches.
Great, thanks. Yeah, that's very helpful. So it gets to the question of the timing of when people relapse. And I've always thought that it's pretty much a random chance, you X% per year, but it seems like, obviously from your work, it may not be. Is there, maybe you can spend a couple minutes on the timing of and what the difference is between if you progress in the early versus, much later.
So I'll put it in context by saying that most patients with follicular lymphoma will do very well. Even if their disease returns, the likelihood of successful retreatment is high. And that's one of the things that makes me really happy about being able to treat this disease, is I find it to be a very hopeful space within oncology. So I just want to put that in context. So I view follicular lymphoma very much like a journey, and it's a marathon. It's not a 5K, it's not a sprint. It really is a marathon. And so each milestone is incredibly important. And as someone who has run a marathon, I can tell you that getting to mile 18 is impossible if you don't successfully make it to mile 5. So every little tiny step is super, super important. So with that in mind, when we think about follicular lymphoma recurrence, the vast majority of patients will not recur early, meaning they won't have a recurrence within 24 months, or what we've called POD 24, progression of disease, POD 24. And that tells us that 80% of patients will recur after. And so when you think about that more, what we call a more favorable group, those that relapse after, patients in general have, what we've shown, what our research has demonstrated, is that they may have a life expectancy that's similar to the regular population. What's different about relapsing early? Well, what we think is that a lot of those cases are driven by transformation to an aggressive lymphoma. The data is mixed on that. It can be as low as 30%, 50%, as high as 75%, based on the study that you follow. But even if someone has an early relapse with follicular lymphoma, it may not be as a serious problem as transforming early, but it's still not as favorable, if you will, as having the lymphoma relapse after that time. So what does that mean for us as the oncology community? Is we want to focus our efforts on understanding who are those patients. Can we identify them early? Are there tests that we can administer? Genetic testing, blood marker testing, biopsy assessments that can help us understand who is in that pool, and that's an area of our active research right now. However, again, even for patients who relapse after the 24-month mark, there are other features that we would look at to assess how to treat them. Are there clinical trials that may be appropriate? And this is an area of ongoing investigation right now.
Okay, thanks. So Fiona, I want to turn to you for a minute and sort of tell us a little bit about your experience. How did you know something was wrong at diagnosis? How did you know something was wrong when it transformed? And sort of just tell us how those things happen and how you felt about them.
Yeah, sure. Well, I had a lump in my neck, which I went to a GP about quite early on, and he dismissed it and said everyone had lumps in their necks, not to worry about it. And so I sort of ignored it for a while, and then mentioned it to another doctor while I was taking my daughter to an appointment, and he looked really concerned and sent me off for some testing and a biopsy, and it came back as follicular lymphoma. And initially I was quite shocked and did all the reading online, etc. And then after a period of time, things settled and I was on watch and wait, and I got used to the idea of watch and wait for cancer, which is something I think as a patient that's quite, you're unfamiliar with initially. You normally hear that cancer needs treatment quite quickly. And I was going along quite well. And then I suddenly got a lot of fatigue, and it wasn't normal fatigue. It really feels to me like my body's sort of filled with cement when I get a cancer fatigue, and it's very hard to move and I feel heavy. And I also got a painful lump in my neck, another one, and it was so painful that it hurt to turn my head. So that is the point at which I went to a hematologist. And initially, he was quite dismissive as well, and said it was probably due to virus. And I just knew as he was saying that it wasn't right. And I was sort of trusting my instincts and sort of did a deal with him. He said to me, come back in a few weeks if it hasn't gone and I'll refer you for a biopsy. And I sort of said to him, instead of taking more time off work, would you mind just writing the referral now? And if it hasn't gone in a few weeks, then I'll make the appointment. He agreed to that. And I thanked him and left the office and got on my phone and made the appointment for a biopsy immediately. And it came back as diffuse large B cell. So I guess the lesson for me in all of that is to trust your instincts and stay in tune with your body. And if you believe something's not right, explore it and keep exploring until you're satisfied with the answer.
Thank you. Yeah, I think that is key. That you know your body better than the doctors, and you have to advocate for yourself. Can I ask you the two different biopsies? Did they take the whole lymph node out, or did they just put a needle in?
At first diagnosis, I had a fine needle biopsy, and that was inconclusive. And so then they did more biopsies. But the second time, I don't think they bothered with the fine needle, just went straight to a full biopsy. And the first time they took out the whole lymph node and unfortunately must have nicked a nerve, and I lost the use of my arm for 4 months. And was sent to neurologists and all sorts, and no one knew what had happened. And I think I was even suspected maybe of putting it on at some point, maybe for workers' compensation, but I was still working and, going through life normally, but just with one arm. And after 4 months, the nerves must have regenerated and I got the use of my arm back. But it sort of was a bit of a learning episode that no one really knew what had caused the loss of my arm. So it was sort of a questionable period. And I realized that there's a lot of question marks still in science and medicine, and you don't always have the answers.
Carla, any comments on the biopsies and that sort of thing?
Yes, I just want to say, wow, what a story. That's pretty incredible. And I'm sorry that it sounds like it was a very challenging time in your life, and I'm really sorry to hear that. But it's not uncommon for a lymph node to appear sort of not worrisome. And if you think about the fact that lymph nodes are part of our normal anatomy, and it's okay for lymph nodes to be enlarged when your body is doing something, what I call behind the scenes. We may not necessarily understand, but our body is working really hard for us all the time. And there may be infection, injury, inflammation, something happening that we're not aware of. And so it would be a natural conclusion to say, well, it's probably normal. But to your point, if it doesn't go away, or if it hurts, or if something is limiting you, that absolutely needs to be pursued. So I really commend you for advocating for yourself and getting to the answer. So yes, I think that everything that you described is sort of right on point. The smaller biopsies are hard to make a diagnosis because the material is really small. So if you think about, I would say three, if I could just talk a tiny bit about the biopsy, I think this is an important point, but there's three different types of biopsies. One is a fine needle biopsy, which is a very hollow needle and it sucks out some liquid material from the lymph node. The second one is a core biopsy, which is a slightly hollow needle, takes a bigger piece, and then there are multiple passes that go through the lymph node. And then the third one is what we call a surgical or an excisional biopsy. That one gives us the best information. So unlike other cancers, lymphoma is a cancer of the white blood cells, the lymphocytes, but the lymphocytes live within a group of other cells. They are within what we call a tumor microenvironment. And all of that supportive infrastructure, all of that architecture is really pivotal for us to be able to compare the abnormal cells against its background to see what's the what's the shape? How many of these cells are there? What is the organization? And when you have a bigger piece of tissue, then you can cut it up into many, many, many different glass slides, and then we can look at that under the microscope. So the bigger the biopsy, the more testing that we can do and the more information that we can gain. So often people ask about which biopsy is the best. And personally, I always favor a surgical biopsy if it's safe and possible, because we can get a lot more information from it.
Yeah, great. I think especially for the question of transformation, sometimes it's very important because you can
Absolutely.
miss the transformation if you just take a small sample.
Exactly.
So Fiona, your story brings up a significant question about how you talk to your healthcare provider, your healthcare team. So Nick, if you could put the next poll up, which talks about have you talked specifically with your healthcare providers about progression or transformation. We'll put that poll up. And while we're waiting for that, I think we talk about, obviously Fiona felt something different when it came back or when it transformed. I think you've talked a little bit about this already, but the key warning signs, other than just listen to your body, something is clearly different. People talk about the B symptoms, the fevers, the night sweats, etc. They are not maybe as common even with transformation. What are your thoughts on any specific symptoms that you tell your patients to look out for?
Right. So no, that's a good question. And I get that question a lot. So when you think about transformation essentially means that the lymphoma has evolved biologically from something that's slow growing to something that's faster growing. And in general, any faster growing cells will patients will have more symptoms with that. So for example, night sweats, fatigue, weight loss, lack of appetite. There could be a pain that's different or new. For some reason, not for some reason necessarily, sometimes patients can have pain with lymphoma, depending on if it's pressing up on certain structures, and that's an important thing. And it's important more so because transformation can coexist with follicular lymphoma. So someone can have part of their lymphoma transform, and that part of it is what's behaving more aggressively, but yet the other part of it remains follicular lymphoma. So for instance, someone might feel a rapidly growing mass on one part of their neck, and yet they have a lymph node under their arm that is exactly the same size as it's been for months or years even. And that's always something that you need to take into consideration, that you can have this discordant process where some of it is transformed and some of it isn't. So hence, again, the biopsy being very important.
So that raises the question, and I think there were some questions about this from the registrants about PET scan, and if you think it's come back and or transformed, you do a PET scan. How valid is the SUV, how hot that uptake you were talking about earlier is, and does that guide your biopsy? How important is that when you're sort of thinking about how you evaluate a patient whose disease has come back?
I think it is important, and I use the PET scan as sort of the bookend to your treatment. So someone gets a PET scan at the beginning just to kind of mark where we're starting, and then a PET scan at the end to mark kind of where we're ending and see the difference in between from treatment that's been done. So what often happens is someone has a CAT scan, that CAT scan raises concerns. Then we say, well, this is something we need to pursue a biopsy for. A PET scan might help us to identify the area that's most metabolically active, because we want to increase the likelihood of finding transformation. And so, yes, the SUV, which is the standard uptake value of those lymph nodes, is going to, in general, be higher in someone with transformation. Follicular lymphoma can still sometimes have high SUVs, but if you have a choice between several lymph nodes, and then a group of them has an SUV of, let's say, 4 to 6, but there's one that has an SUV of 25, you absolutely want to pursue that one if you can, because the likelihood of finding transformation will be higher, and that will certainly affect the therapy that you pick.
Thank you. So Fiona, when you told us how you advocated yourself and got the biopsy, and and they found transformation. Can you talk a little bit about how the discussion went about what treatment you would get for that? That might have been different than what they talked about earlier, saying, well, if you have follicular lymphoma, we're going to treat you with this. Was there a change in what they were talking about when they said, gee, it's transformed, so you need this other treatment?
There was definitely a sense of urgency once I was diagnosed with the aggressive cancer, and I was, called at work and told, I think I started treatment about 2 or 3 days later. And I think it was quite an automatic assumption at the time. I think R-CHOP might have been the standard treatment for that particular progression. So that was explained to me. But I think the choice that I had was whether after the R-CHOP, which took about 6 months, whether to do the rituximab, the maintenance, or not. And I remember getting an opinion from 2 hematologists, and they differed on their opinion. So I guess as a patient, that's when it becomes a little bit difficult. And I remember saying to one of the hematologists, if it was your family member sitting here, what would you tell them? And he said to me, I'd say do it. So on that basis, I said I'd go ahead and do it. I'm not sure if that was the right call. But at the time, with the information that I had available to me, I said I'd go along with that.
So, Carla, there's a lot to unpack there in the decision-making process. So I'll let you take whichever points in there you want to highlight.
Right. So I think, Fiona, the treatment that you had was highly successful. Clearly, you're still here doing well. And for someone that has transformed lymphoma, and someone in the chat asked whether all transformations are diffuse large B-cell lymphoma, not all of them are. Some of them are transformations to a different form of aggressive lymphoma, one called high-grade B-cell lymphoma, for example. So just to give some context, but the majority are diffuse large B-cell lymphoma. But the treatment for transformation is entirely contingent upon the treatment that someone had first. So there are some very well-established treatments for follicular lymphoma, which include the treatments that we use for aggressive lymphoma. So for example, sometimes follicular lymphoma is treated with R-CHOP at the time it's diagnosed, and sometimes it's treated with another regimen. There are many regimens to be used at the time of someone's first diagnosis. Sometimes it's bendamustine, sometimes it's CVP, sometimes it includes lenalidomide. So there are lots of different choices. However, if someone either is observed or has rituximab, has not had any chemotherapy, and then they go on to have transformation, R-CHOP is the most appropriate choice at that time. If someone has already had R-CHOP at the time of their follicular lymphoma diagnosis, we usually do not repeat R-CHOP again, for a few reasons. One, there's a lifetime limit to how much anthracycline someone can receive because it can be toxic to the heart. And the anthracycline is the doxorubicin, or the H medicine in the R-CHOP. And so a different selection would have to be made at that time. Sometimes it's ICE, sometimes it's a clinical trial, sometimes it's another form of therapy, sometimes it's CAR T. It sort of depends on the person and their history, but it's appropriate only if someone really has either had no R-CHOP or has had limited R-CHOP in their lifetime. And so the question about maintenance is also somewhat controversial. And, to your point, Fiona, there's so many opinions out there because oncology is both an art and a science, and we interpret the data in different ways, and we have to base it on our individual patients standing in front of us. And so someone who's, perhaps younger versus someone who's older, someone who has many medical conditions and is maybe somewhat frail compared to someone that's very young and otherwise healthy and fit, those decisions are really very, very individualized. So I think I covered most of those, but let me know if there's anything else I can elaborate on.
I think, there are some questions about rituximab maintenance, and it's a very difficult area for follicular lymphoma. And so when you have transformation, we might not use rituximab maintenance for DLBCL, diffuse large B-cell lymphoma, but now you're treating both because you say, well, the follicular is still there, And
Right.
so that's why I think the argument for reduction.
Yes.
So there is no
Yes.
one right answer. I think that's
No, there really isn't. I think it's reasonable. I certainly have done it myself on some select occasions. I wouldn't say it's as routine anymore, but certainly many physicians would offer it or consider it.
yeah. So if you've transformed and you've not been previously treated and you're diffuse large B cell, then R-CHOP is still, I think, the standard. There are some wrinkles to that, which we're not going to go into here. What if you have had R-CHOP? I mean, you mentioned a few things. There's the field of DLBCL is changing rapidly. There's all these sort of new drugs, CAR T, bispecifics. There's some discussion in chat about lenalidomide rituximab, otherwise known as R-squared. That's more of a follicular, but it has some activity in DLBCL. Do you have a general path, or is it really individualized for each patient?
Right. I think it depends on a few things. It is very individualized for a couple of reasons. We actually just studied this in our big consortium, and we're in the process of publishing these findings. But what we've noticed, at least in the US and our multi-center consortium, is that the patterns of care for transformed lymphoma are very, very variable. It depends on what the patient had before, again, their underlying health. Someone who has a transformation, it may not be their first or second treatment. Sometimes transformation happens after someone has had multiple treatments, and so you have to take that history into consideration. If someone has had multiple treatments and they've had a transformation as their perhaps, let's say, third or fourth progression event, then you might consider something slightly higher intensity at that time. Perhaps CAR T cell therapy, if it's available and appropriate for that particular person, that would be in the United States an approved treatment choice in that situation. In other parts of the world, perhaps a stem cell transplant could be explored because CAR T cell therapy is not available everywhere. But it really depends on what the patient has had in the past and sort of how many treatments for follicular lymphoma were had. Did they include R-CHOP in the past or not? How quickly did the transformation occur? And then what's currently available for that patient in terms of clinical trials or treatments for aggressive lymphoma that are accessible to them where they live and in their community.
And then obviously the patient's status and how healthy they are and what they can tolerate.
Exactly.
All of those things, yeah. Fiona, people, we talk a lot in follicular lymphoma, especially of chemo-free regimens, wanting to avoid chemotherapy. How hard was R-CHOP for you? For patients who haven't been treated yet, is R-CHOP, was that an awful experience, or no, actually with our current ways of managing nausea and things like that, it was actually not so bad?
Well, I think I was quite fortunate. I didn't find it too taxing at all, but I think it's quite an individual experience because I've heard of some people who've had a terrible time. I actually found it pretty straightforward and it didn't have too many physical impacts at all. Yeah, and strangely enough, if I think back on that period of 6 months, I lost my hair and there was a few other things, but it was probably one of the most relaxing periods of my life, bizarrely, because I took sick leave from work, and was just able to focus on myself and my health and catch up with friends for coffee and watch Netflix. And so for me personally, I didn't find it too bad, and I didn't find the rituximab bad at all. Actually, I found that barely impacted me physically.
I'm really happy to hear that. That's great.
Yeah, I think that's a lesson, especially people who are in this situation of having never been treated. They envision all of these awful things, and actually, the reality for many of the chemotherapy regimens today are not as taxing as people think. For other diseases, yes, I'm not going to say chemotherapy isn't bad, but we're fortunate in that many of our lymphoma treatments can be handled pretty easily as an outpatient and that sort of thing. There's a lot in the chat here about different scans. I know we did talk about PET and CT a little bit, but like someone's asking about ED versus complete metabolic response. And, Carl, you talked about managing PET scans at the end of treatment. Can you talk about when you have an end of treatment PET scan and it's negative, what you tell a patient, and maybe talk a little bit about NED and CMR?
So CMR stands for complete metabolic response. And what that means is that on the PET scan, we see no abnormal metabolic activity. And that's what I was mentioning earlier, that lymphoma can have some energy uptake compared to your normal body. And if there is any residual energy utilization, then that's not, then we assume that there's still something there. It could be lymphoma, it could be something inflammatory, it could be the cells that are still dying. But complete metabolic response means that we don't see any evidence of anything on that PET scan aside from the normal energy that your body has. NED stands for no evidence of disease. And so theoretically, having a complete metabolic response and being NED, they're equivalent. And so if someone has an area of lymphoma, let's say, in a different part of their body that the PET scan is not able to really see, you may not know 100% if having a complete metabolic response on PET scan equates to being without any evidence of disease, which is NED, but by and large, they really mean the same. And someone in the chat also asked about cure, and I think I'll touch on that in the context of this question, and that is that I believe that some patients with follicular lymphoma can be cured. That, I have to say, is a very controversial area within lymphoma, and many doctors have different opinions about that. But if you think about the fact that follicular lymphoma can be a disease that someone has for 20 plus years, 30 even in some cases. And again, if we think about that population of patients that maybe if they don't have a recurrence early in their lifetime or early after their diagnosis, or if they don't have a transformation early after their diagnosis, they seem to have the same life expectancy as the general population. I think that we can start to embrace that concept that perhaps some patients can be cured, recognizing that this area is extremely controversial in the field of follicular lymphoma. And, there are varying opinions on that, but that's an area that I'm really interested in studying and understanding better. But I remain optimistic that there are some patients that can be cured.
I'm glad to hear you say that. One of the things that attracted me to the Follicular Lymphoma Foundation was the idea that we were going to cure the disease. And one of the things that comes up is, how do we know, right? You have to wait 20 or 30 years.
Right.
So now people are looking, my PET scan is negative, that's good. There's a question in the chat, and I was going to prompt me to talk about blood tests for minimal residual disease. Can you find the tiniest hint of disease? And if you do, then probably you're not cured. But if you don't, where are we going in the ability to tell people I'm cured, or at least I'm going to not come back for 10 years or something to ease the anxiety of that concern for relapse? So are we making progress in that direction?
We're making a lot of progress. So minimal residual disease is sort of a term that we use to understand whether we can see any evidence of follicular lymphoma cells in the blood or any DNA or evidence of on a molecular level, do we see any evidence of follicular lymphoma in the blood or in the bone marrow? That's not really considered part of our standard practice yet. Those are really investigational at this time. But we're trying to put together PET scan information with circulating tumor DNA or minimal residual disease information, along with some other clinical features of the patient to kind of kind of map who is more likely to be in that group. There are some tools that we have. One of them is called the Flippy. One of them is called the Flippy 24. There's some online calculators, especially for Flippy 24, that you can use based on blood work and things that can give you a sense of what category someone falls in, recognizing there's no 100%. People's lives can change and things can happen. But those are ways that we're starting to understand who might be the patient that has a little bit more of a increased likelihood of being that cured patient or having a long life expectancy. And then I'll just quickly touch on a brief point that came up in the chat for young adults. So about 10% of follicular lymphoma will affect people under the age of 40. And we have done research on that group of patients and have found that it's not necessarily a disadvantage in the sense that you have it for longer, but patients who are younger seem to do comparably well to the general population. But because follicular lymphoma is a disease that typically patients have when they're older, in their 60s or 70s, it's not everyone, obviously. Some people are younger. But I remain optimistic that even if someone has follicular lymphoma as a young adult, they can still have a very long, full life. I have many, many patients in my practice. I see a lot of young adults as well. And I have been extremely pleased with how patients have been doing. So you're right that 20 to 30 years in someone who's 20 or 30 years old is not a long life, but I think that we're going to be getting better and better and better at helping patients live longer.
Great, thanks. Fiona, how are you dealing with the idea that you're in remission, but you had follicular, you've been treated? At some point, the DLBCL may be less likely to come back, but follicular's in the background. Just how do you deal with that kind of? Does it just put it out of your head, or how often do you get seen? Do you have anxiety around those visits? Just give us some sense of how you deal with that.
Probably the best description in my case would be that it's at the back of my mind, not the front. So I tend not to let my diagnosis define me or be forefront in my decision making. However, it's in the background, and I think it's probably easier to have that attitude when you're feeling well, and it becomes more difficult when you're not feeling well. But for me, I think we're all fighting to stay alive and have quality of life. So while we've got it, we might as well get on with living. So my philosophy is find things you're passionate about, engage in work or artistic pursuits or whatever it is that you enjoy, get some satisfaction, stay connected to community, friends, family, environment, and just live a full life as much as possible. At the same time, do what you need to do to take care of your health. At the moment, I'm 6 monthly checkups, and I really don't think about them at all. I don't even know when they're coming up until the week before, probably. In my calendar, I see it. So it really isn't a defining factor in my life at all. And I'm grateful that I feel well, so I'm able to have that attitude. And I realize not everyone's in that position, but I think if you're feeling well and you're alive, you might as well live your life to the fullest.
Great, excellent. So one of the things that patients always ask, what can I do to keep it from coming back? And they always want to do something. They want to control, which I certainly understand. As doctors, we often just say, everything we tell you, everyone to stay healthy, you should really do, like eat well and get a diet and things. Actually, Fiona, are you doing anything, or are you just doing all the usual things to stay healthy? And Carla, do you tell patients, is there anything? So Fiona, I'll start with you. Are you doing anything particular other than your great mental attitude, which I think has a huge amount to do with it?
I would love to say that I'm a fitness fanatic and I'm a healthy eater and I don't drink any wine, but it's not the truth. Okay. I'm generally quite healthy, I suppose. I do a lot of bushwalking and hiking, and I walked the Camino last year and things like that. But I love a red wine and a G&T in summer in Australia. So everything in moderation, probably. And I think my view is, if I gave up chocolate and red wine and I died from lymphoma, I'd be really pissed off. So I might as well enjoy it while I can, as long as it's in moderation.
Good attitude. Carla, any magic potions or?
I really think that your mental state is so pivotal, and I'm so pleased with everything you're saying, Fiona. It's so inspiring to hear you really take life and live it to the fullest. And I really encourage my patients to do the same. I think that that's one of the things that being an oncologist has taught me, is that time is so precious and it gives you perspective on the things that are important. So I agree. I think everything in moderation. And that said, I mean, there are some data coming up recently that show that exercise has been one of the most important risk factors against reducing the risk of death and reducing the risk of having medical conditions and complications from medical conditions. The more exercise, the better. There isn't a magic number, but that's one of the things that has evolved as one of the most important changes that someone can make. If you don't exercise, you can start. If you exercise a tiny bit, do more. If you're already doing it, then great. But that's one thing that has been really shown to have an appreciable impact. A diet too is important. And towards a plant-based diet when possible, Mediterranean-based diet, things that reduce other risk factors from heart disease and things like that will certainly appreciably help you stay healthy in general. So those are things that I follow myself and that I encourage patients to do for themselves as well.
Great. We have a few minutes, and I'm going to come back to a few other questions. But Nick, if you could put the last poll up about how people, we're trying to see if we've had any impact in people's understanding of progression and transformation. And while that's up, Carla, so there's a lot of new therapies out there. We sort of briefly touched on them. We don't have time to go into them. We mentioned CAR-T, bispecific antibodies. And we had a previous session on clinical trials, talking about the importance of clinical trials in general and availability and things like that. Where do you see, particularly for I would say too, for POD24 and the early progressors, where do you think we'll be in the next few years in terms of predicting that before it occurs?
Mm-hmm.
And second question is, where do you think treatment's going to be in the next few years for these?
Right. No, those are really good questions. And those are questions that we get asked a lot. So in terms of predicting who will have POD24, this is really a global effort where many, many investigators are putting their heads together to figure out how can we identify patients early that might be at risk of having early progression from follicular lymphoma or early progression from transformation. And I'm really pleased to be a part of many of those ongoing efforts. And I'm optimistic that we'll be closer and closer to that every year. Not quite there 100% right now, but we're getting closer. In terms of treatments for POD24, it depends a little bit on what the patient had before their event, whether or not they've transformed at POD24 or is it follicular lymphoma at POD24. There's a lot of clinical trials exploring this question and a lot of new treatments that are looking at treating everyone with relapse, but then focusing on the smaller group with POD24. And what we have seen thus far is that patients seem to respond very well to treatments that the general population will receive. The difference is that they may not last as long in some cases. That's not really a generalization, but in some studies we've seen that perhaps the treatment just doesn't last as long as in the general population. So the crusade is ongoing to really understand what the best treatments are. But I think that the likelihood is that the treatments for patients with relapsed follicular lymphoma will be effective for someone with POD24. And then in a very detailed and meticulous discussion with your doctor, they can determine with you whether more might be necessary. Should you think about CAR T cell therapy? Should you think about transplant? All those important questions are very, very individualized and, kind of made one-on-one.
Great, thanks. Well, okay, here comes the pull up. So I think if you look, the shift is pretty good here. I feel good that we've managed to get half the people into up to grade 4 and 15%. So totally 2/3 of the people are in 4 and 5. So we definitely feel that people feel better about their understanding this. And it is clearly complicated. We don't have all the answers. As Dr. Kusulo said, it's an art and a science here. And I guess one question is it's come up in the chat and we all ask it, is where do we understand the biology of what do the patients have a different biology underlying this? And would that then, if we understood the biology, allow us to give more targeted treatment? And I think that's a hope. I don't know if you have any comments, Carla, on where we are with that.
No, definitely. There are changes. So when someone has follicular lymphoma at their diagnosis and then it transforms, I use the analogy of a cluster of grapes. So you have sort of a cluster of green grapes at the time of diagnosis, and then at the time of transformation, it's now red and green grapes. So some of the lymphoma is similar and some of it is different. We now understand from a biologic standpoint that there are some features that are shared between the initial follicular lymphoma and the transformation, but there's sort of like a divergence that happens over time. Something shifts. the biology changes. And sometimes, yes, you can find those nuances when someone is diagnosed, but what we don't know is when and with certainty. Is it 100% chance that that will happen? We don't know that yet. So we know that there's differences in biology, and we know that those biologic differences can shift over time. And so that's kind of where we are right now.
Great. And, you know, there's a couple of questions in the chat about rituximab, either early watch and wait or maintenance. Do we have any idea that any treatments impact or can reduce the risk of transformation?
Yes, we do. In fact, this is also an area of a lot of data and a lot of study. And what has been demonstrated is that someone that has observation is appropriate for other things too. Someone with observation could sometimes go on a clinical trial, can sometimes get rituximab. I think the difference is in whether treatment is desired or not. And yes, occasionally there have been some studies that have shown that earlier use of rituximab can reduce the risk of transformation later on. It does not all studies have proven that. There's some differences in the data, but many have suggested that if you treat someone early, perhaps you can lower the risk of transformation if you treat them with rituximab. But again, the data is somewhat mixed on that. It
Yeah,
depends
and
on,
I see.
yeah.
Say there are new
Okay.
trials with bispecific antibodies early,
Yes,
and it'll be interesting to see if there's any chance that that might be even better than rituximab in preventing transformation. And that's an argument for if people are interested to be on clinical trials looking at those sorts of things.
exactly.
Okay. Fiona, any last thoughts after hearing all of this?
No, but it is heartening to know that there are researchers and professionals out there focusing purely on follicular lymphoma and finding a cure. I think that's wonderful, and it's almost like the longer we stay alive, the more chance we have of staying alive. So
Yes.
yeah, it's just really promising, and really grateful that there are so many people focusing on it. It's wonderful.
Yeah, I think that is a key, is that, you know, we talk about cure and we would love to cure it, but if you can stay ahead of the curve, there's so many new treatments coming that, you know, in the time I've been doing this, and you know, the number of treatments and the outcomes and the ability to keep patients from one treatment to the next has increased so much. It's really remarkable, and we expect that to continue. All right, so I think it may be time to wrap up. We got just a couple minutes left, so I want to thank sponsors. Well, first I want to thank Carl and Fiona, Dr. Casula and Fiona, for their excellent insights. It's been very informative. We do thank our sponsors who have supported this educational initiative. I want to thank all the FLF team behind the scenes who make this possible. We do have upcoming webinars in May and July, so look out for the topics. We really do appreciate your feedback both on this particular one and any topics you'd like to hear about in the future, because this topic came out because you know, our community asked for it. Again, we encourage anyone, if you have ability to go on a clinical trial, we think that's great. We do have a clinical trials webinar you can see, as well as the seminar on the webinar on relapse in general, which covers some of the similar topics. Look out on our social channels and website for updates. We do have patient stories on our website. We love to have people who are willing to share their story, inspiration and problems and concerns. So get in touch with us if that's something you're interested in. And again, I want to thank everyone attending today, everyone who watches it in the future. And again, Fiona, Dr. Casulo, thank you very much for your time and efforts. That's it for us from today. And thank you. Carla, last minute.
Yeah, thank you for the invitation. And it was really fun for me. I'm happy to help answer any questions that might have been outstanding. If there's a way to address anything else, I'm more than happy to address any other questions. So yeah, thank you so much.
We will press you into service for that. Thank you.